To be here today. I think this is the key to success in bringing together patients and doctors and researchers and scientists and nutritionists and mental health professionals. This clearly is a situation where we need everybody to come together. Silos have gotten us where we are today, and we need to come up with a different model. So, of course, this is why we're here. You know, diabetes is the trajectory is, oh, it's bad. We're going straight up. It's not getting much better. Pre-diabetes, even more frightening. It's the numbers are climbing every year. We know that there's a lot of impact regarding health disparities, that different populations are impacted much more severely than others, as it is with a lot of health-related issues. Diabetes is no different. And of course, we're adding fuel to the fire because obesity numbers, oh dear, we are having some issues here. So the prevalence in the United States, depending on where you get your numbers from, almost 42%. It's increased significantly across all age groups, all demographics. It's just this problem that doesn't seem to care who you are. There's an obesity problem. So we all know why we're here. We also know that it often hits certain populations at higher rates. And so here are some of the challenges when we're talking about obesity specifically. It's an uncomfortable topic to bring up. If you're in a medical visit and you're the patient or you're the provider, nobody wants to talk about this because everybody's uncomfortable about it, right? Partly because we haven't really been able to do a whole lot about it. But secondly, and for a lot of reasons that Lori brought up, and I could get up here and say ditto and be done, but there are a lot of there's a lot of shame associated with it on all sides. But it is so uncomfortable, and communication in itself is a challenge, but communicating about topics like this is even harder. It is a very complex issue. I wish it were as simple as eat less and move more. We're done. I wish. But we all know that it's not. There are personal and behavioral factors. There are genetic and environmental factors. There's also the media and social media factors, which are not helping, by the way. Weight stigma and stereotypes and stereotyping is really impacting healthcare at the physician, nurse, patient level. It's leading to less than adequate care. In fact, it's not just less than adequate care. It is causing a lot of detrimental outcomes that we'll talk about a little bit. Health disparities, social determinants of health, we know contribute to obesity. If you look at health beliefs, cultural beliefs, we know that even zip codes matter, right? So it is a complex issue. But can we agree that everybody is frustrated? Physicians, patients, nutritionists, nurses, family members, everybody is frustrated. The patients feel disrespected and invisible, and healthcare providers find patients defensive and non-compliant. I hate that word non-compliant, but that's the one we like to use. Patients with obesity get tired of every office visit being about their weight. If you come in for an earache, somehow it becomes about your weight. Apparently you have fat ears. I don't know. But everything becomes about your weight. You can't go in for a broken hand without it becoming about your weight. Everything is about your weight, which also can lead us down some paths that really can cause some problems. Physicians are really trying to do their job. So if anybody thinks I'm anti-physician, I am not. In fact, I oversee graduate medical education. I'm trying to help create physicians that are really clinically competent, compassionate, uh, patient-centered. But physicians are trying to do their job, and patients are resistant. Of course, they're resistant because typically the approach that's being applied is not working. And so everybody's frustrated. So what's contributing? Evidence shows that both medical doctors and the general public hold strong explicit and implicit weight bias. Lori talked about this. So there's this common idea that it's their own fault for being overweight. All of the fault lies with them. All of it. Every bit of it. And you should be embarrassed. Well, okay, we are. Yeah, we got that part down. But it justifies people treating them with disrespect, disgust, and ridicule, right? Because if it is a moral failing, we feel obligated, in fact, somewhat, well, it's our moral duty to make sure we know that you should feel bad. And I don't even have to know you to make sure that I fulfill my moral contract, my social contract, to make sure that you feel bad about your weight. The one thing, and this is what Lori brought up, is we carry our issues very publicly. You can be a drug addict, you can be an alcoholic, you can be a heroin addict, you can be a gambler, you can have a sex addiction, and nobody necessarily has to know. But if you have issues around weight, everybody knows. You cannot hide it. All right. So weight stigma is pervasive, and it's driven by increased shame and blame coming from also social media, right? We know that social media, from a mental health standpoint, is not helping anybody with anything. Substantial evidence shows that weight stigma is not only unfair and unjustified, but creates health disparities and hampers healthcare and healthcare outcomes. In fact, I will tell you that, I'm a 3-time cancer survivor, and my third bout with cancer was delayed 5 years in diagnosis because all doctors would do is contribute it to my weight or attribute it to my weight. You're bleeding uncontrollably and hemorrhaging, well, because you're fat. Nobody, and I'm talking over multiple doctors, ever thought maybe we should do an ultrasound or some, we should maybe do a biopsy, or maybe we should find out why this is going on, because it was attributed to my weight. And I'm sure I'm alone. I'm sure that's never happened to anybody else everywhere, anywhere. I was just incredibly unlucky, I'm sure. Several studies show that healthcare providers have implicit and explicit anti-fat bias and report that patients with obesity feel stigmatized by their providers. So this perceived bias decreases the likelihood that patients will seek care. They don't want to come see you because they feel bad after they see you. And it's not feel bad as in, wow, they were right. They care deeply about me. It is, I just feel bad. I feel less than. I feel humiliated. And why would anyone go back to that person that made them feel that way? And by the way, if you don't know, if that's how you think, if you have the fat bias, the shaming, the weight bias, and you think that you're such a professional that your patients don't know, you're wrong. We know. We know. There's something called nonverbal leakage. It sounds like a medical problem. But non-verbally, we cannot prevent others from knowing how we feel. we can't help it because it manifests in how we talk, how we touch, how we engage, all of it. If you know how other people feel about you, your patients know how they feel about you. So, obesity stigmatization has been shown to negatively impact a person's ability to lose weight because when you leave your office, they are upset and eat. Or it manifests itself in maladaptive coping mechanisms, binge eating. I'm not saying that that office visit caused binge eating. I'm saying that it can be traumatic and causing additional problems. But what it does do is create feelings of more shame and stigma, and then the circle continues. So the very place that people go to try to for healing and support ends up sending them deeper and deeper into what they went to go see you for in the first place. Disrespectful treatment and medical fat shaming in an attempt to motivate people to change their behavior is stressful and can cause patients to delay healthcare seeking or avoid interacting with providers. Yep, avoidance. A lot of avoidance. And evidence confirms that fat shaming is not an effective approach to reducing obesity or improving health. I think this we can agree. So we have to do something different because what we've been doing, it ain't working. If we were that successful at it, our numbers would not be climbing. So what fat shaming and weight bias looks like in healthcare. Reinforcement of negative stereotypes. This is the number one thing that is so heartbreaking when the patient's story is automatically dismissed. When they're told they're lying or their experiences are not what they are reporting, or what they've done was completely self-induced. So you did this to yourself. Communicating disappointment discussed verbally and or non-verbally. Not offering standard of care because of patient's weight. There is plenty of evidence out there that shows standard of care is not provided to patients who are obese. Not offered the same tests, not offered the same options. Once again, partly because the medical community were so incredibly focused on the biomedical model, right? We see something, we fix something, right? This is what's wrong. This metric, because by the way, it's easy. Weight is an easy metric. This other stuff you want to talk about, you know, the neurological issues or the mental or emotional or spiritual stuff, not so easy to measure. Not so easy to address. There are no quick fixes, but there aren't for weight either. But you can't do that for weight either. As it was said earlier, weight is a symptom. That is not the problem. Inappropriate comments. Blaming the patient without considering other factors. It's obviously how much you eat. You're obviously eating multiple pizzas sitting at home on your couch. Not even considering there are metabolic issues, that you have PCOS or thyroid issues or a host of other things that are going on. Nope, it's because you just sit around eating pizzas and bad food all day long. That's what you do. Making patients feel worthless, mentally weak, or lazy. It's simple math. Calories in, calories out. Does anybody really think that is it? 100%? That's it? That explains 100% of the variance of a weight issue? No. Or a health issue? No, it's not. So fat shaming also looks like when you don't provide gowns that are large enough for your patients. Let's humiliate them a little bit more. If they don't feel bad enough, let's make them feel worse. Not having armless chairs so they have a comfortable place to sit. Having the scale out in the open. You know, when you parade your patients out in them, because the first thing they make you do is get on the scale. So let's do that out in the open where everybody can see it, and then say the weight out loud. I think that's a great approach. I can't see why anybody wouldn't want to come back for that. Or, oh, now they're fooling you. They're putting it in kilograms, right? But they also will say things like, oh, oh, oh dear. Nobody needs that. Not providing appropriate support. Judging a patient for not being able to follow a highly restrictive diet for a long period of time, and that's all you've offered. No other support. Making patients feel like failures because they were not successful. Saying, this isn't rocket science, just eat less and move more. So we need to do better. It's not the physician or the provider's job to walk around monitoring patients at food intake. It's not. And not to make sure we do the right thing when we leave your office. That is not your job. The ultimate responsibility does fall to the patient and the part that they own, the part that they need to deal with. But we need your help. What we don't need is more psychological distress. When we do come to see our healthcare providers, we need a partner, not an adversary. So as a patient, a social scientist, and a professional in the healthcare field, I am hopeful that my story can help. But first, water. In February 2021, I was diagnosed with diabetes. My A1C was 6.7. I'd been pre-diabetic for years and had plenty of opportunities to make healthy changes, but I didn't. I'd been watching my brother Eric fight complications of diabetes for the past 10 years. His kidneys had already failed, and he was on dialysis. He fought an infection in his foot for over a year, but finally had to have it amputated, and now he had another infection to fight. He was my baby brother, 51 years old, when he died. And I always put his picture up there because he's a big part of why I do what I do. Because people are dying. And we have to do something about that. So this is my story. That's me on the left. Don't we love pictures? Don't we? We do. Okay, so BMI of 41.6. My A1C was 6.7. My blood pressure was semi-controlled by medication. I had bad neuropathy. And I was a 3-time cancer survivor. This was February 2021. I keep forgetting to change that slide. That picture was 2020 though, because we just moved to Gulfport, Mississippi at the very beginning of the pandemic. And that was me. And so the day I was diagnosed with diabetes, I joined Weight Watchers. I had been successful many times losing large amounts of weight. In fact, I had lost 100 pounds at one point, and then I got thyroid cancer. And when I used to do stand-up comedy, I always said I got the kind of cancer that made you fat, which is an uncomfortable thing to say, but it was true. I gained back every pound that I'd lost due to thyroid cancer, which obviously then messed up my thyroid, the whole thing. And then I got thyroid cancer again because it wasn't treated very well the first time, and so I was stage 4. It had metastasized to my lungs. And so they treated me with the biggest amount of radioactive iodine that they could without killing me. And that was 20 years ago, so I'm still here. I'm pretty happy about that, but it had a lot of side effects. Not the neuropathy, we don't know where that came from exactly, but it killed all my salivary glands, which has caused my teeth to fall out, and I've had to get a lot of implants, and I've had all sorts of other issues. But so the day I found out I was diabetic, I went home, and the person, my primary care doc, sat me down, and he said, "Well, young lady," and I was happy he called me young because I was 57, and I was his boss, so he had to be nice. But he said, "We got to have the talk." And so he sat down in a chair and we looked at each other, and he said, "We have to do something." And I said, "Don't worry, Dr. D, I got this. I know what to do." And I went home and I joined Weight Watchers. I didn't tell my husband. I probably should have. He found out a couple days later when all of a sudden I went to the grocery store, and he went, "Oh, we're going to eat healthy now." And I said, "Yes, we are." And he said, "All right." And so I started with Weight Watchers because I knew that there was a component of it that I had to address, which was I was obviously overeating, surely. It was also self-soothing with food. And I realized I had better figure out why, because I knew the weight was the symptom. And if I ever wanted to truly transform my life and have a healthy life without the anxiety that I've attached to food my whole life, I better figure out why. So I started seeing a therapist. I also started seeing a transformational coach, and they would all kind of bombard me with all these questions about early trauma and why I was self-soothing with food. But that's where I had to go. I had to go back there to try to figure out why I had so much anxiety around food. But change takes time, and there is no magic bullet. There are all these wonderful tools that are out there, and I'm all for tools if they can help you achieve what you want to achieve. I had grown up with food anxiety my whole life. I had it till the day I started Weight Watchers. What I found out was that I'm addicted to sugar, processed carbohydrates. My brain thinks they're crack. And I couldn't figure out why I never felt full. I could eat more food than my husband, and I was never full. And I thought, well, this is absurd. I mean, I know better, but my brain never knew. But I was eating a lot of sugar and a lot of processed carbs. And so 2 weeks, I started eating really clean, right? Just following the directions. And after 2 weeks, I kid you not, my body at dinner one night, my brain said, "Gretchen, you're full." I thought, what is that? That is the most bizarre feeling I've ever had in my life. And ever since then, my brain tells me when I'm full, but I eat really clean. Now, I eat really well, by the way. I do not restrict. I do not, but I eat really healthfully. And so while I'm doing that, I'm also talking with my therapist about early traumas and why I self-soothe with food. And I'm talking with my coach on how to build tools to be successful. And I'm doing a lot of that internal work because I got to find some answers. So I did. And what I realized is that this is not an overnight thing, not even close. And the next time I went to see my doctor, I don't know how much weight I will have lost. But what I did know is I was on a journey toward transformation. Because now my life depended upon it. I was not scared when I was stage 4 cancer. I don't know why, but I wasn't. Even when we didn't know if the treatment would work. But I was scared to death the day I found out I was diabetic because I had watched Eric, and my window oversees wound care. And I watch every day the people who are younger and younger and younger who are coming in without their limbs. And I knew, because that's the future for almost everybody who is diabetic, that was my future. I watched my brother fight hard, and he was so brave. And I knew I couldn't be that brave. And so I knew I had time. And that was a gift that my brother did not have. And so I knew I had work to do. I also realized that mindset matters a lot. It really matters because it drives everything you do. Gratitude makes sense of our past, brings peace for today, and creates a vision for tomorrow. When I started my journey that very night, I said to myself and to who I say my prayers to at night, I said, I'm going to do this with nothing but gratitude. No feeling sorry for myself. I'm really good at that, by the way. No pity parties. I'm not going to be angry at anybody. I'm not going to become the food Nazi. My poor husband, he's like, does this mean we don't ever get to go out to eat? And I'm like, no, that's not what this means. Unbeknownst to me, my sweet husband was taking notes in a journal about what foods and how I ate so that he could be, because he often makes the meals. And if he cooked something that he wasn't sure, he'd leave the box on the counter so I could scan it. So I didn't have to dig through the garbage to figure out how many points it was. Anyway, I realized that gratitude was the way to go for me. And it made all the difference because I was never angry. I was never sad, even for the life I was going to leave behind, which you have to when you're going to forward and in transforming into a new lifestyle. I was nothing but grateful because I had time. And within 3 months, I had lost, I don't know how much, 40 pounds or something. And I went to the doctor and my A1C was normal. And I was never so grateful. And I knew I still had more work to do because I also knew I could gain it back. And I could be diabetic and I could still lose my legs and I could still have my family and my grandkids to have to deal with stuff that I didn't want them to have to deal with. So here's what clicked. Has anybody read James Clear's Atomic Habits? Oh my Lord, you've got to read this book. Amen. Here's what I realized. Motivation fades. Willpower doesn't exist. Please don't tell people to have more willpower. But if you build systems and do small changes, no matter what kind of a day you're having, you're still going to be successful. Mentally, physically, emotionally, spiritually. So I really embrace this idea of small changes done consistently will equal huge results. And it does. There were 2 things that I did that probably contributed the most to my being able to create a healthy body to live in. One is I packed my lunch every day. I ate breakfast at home, so I could control that. And I ate dinner at home. But lunch, especially because I work in a hospital, ugh, not healthy. Never. Lord help us. So I brought my lunch every day. And I still bring my lunch every day. And I've been at goal for 1.5 years. Even when I buy food for my team, I include healthy stuff and I still bring my lunch because I feel enough self-love to do that. I matter now, whereas before I wasn't so sure. So this is me today with a lot of makeup and a little touching up and whatever. Um, but I lost 110 pounds. My BMI, I'm still overweight, by the way, and I don't care. I'm good. I'm good. My A1C is normal. The neuropathy is still there, and I am still a cancer survivor, but I'm still here. That was July of last year. And I'm just doing this because I got those pictures taken this last week. And I like them. And I'm learning how to celebrate myself. And some might say, well, oh, you're celebrating because you are thinner. I'm really not. What I'm celebrating is a life without anxiety, a life without focusing on food 24/7, a life that doesn't have me preoccupied with if there's going to be enough food for me to eat. That's what I'm celebrating. Now, it's nice to be able to shop at Ann Taylor. Okay, I'll give you that. But I am celebrating that I have a normal A1C because now I have more options from a health perspective than I did before. And plus, we also know for cancer patients, eating a lot of sugar is bad because it increases exponentially your chances of recurrence. So I did this to save my life, not just because I would look better. Granted, I look better, but that wasn't the point. And the amount of inside work and internal work I've been doing is what allowed this to happen. So if we talk about how to do things differently, we all know about stages of change, right? If nobody's even ready, if they're not even thinking about making some changes, it's very difficult to get them to action. But I think there's a lot of expectation that if I tell somebody they're overweight and they need to lose weight, that alone should motivate them to make a change. I wish that were true. But we know enough about how the human brain works that that isn't how it works. I used to teach behavior change theory to the CDC. I promise you, we know that that's not how the human brain works. But if you can have conversations with your patients that take them from pre-contemplation to contemplation, that's a huge step. Will it make a difference maybe by your next visit? I don't know. But a year from now, all those small steps could make a difference. But there is some really promising research out there called using the 5A model. And there's a lot of different types of stuff, ways people are using this model, and there's different versions of the model. But from a healthcare provider perspective, one of the things that you can do that helps patients not be so defensive is ask if they're open to talking about their weight, and explore readiness to change. You can ask, is your weight negatively impacting your life in any way? If it's not, then they're probably not, maybe they don't feel they need to make changes. And if they don't, then move on. Talk about other parts of their health. Don't beat them to death just because you're stuck there. If they are perfectly happy where they are, that's where they are. And that's all right. We don't need judgment. We need help. Assess drivers, complications, and barriers. So what's going on in their lives? Can you meet them where they are? Not everyone has the same access to resources. Even if they want to lose weight, a lot can get in the way. So, you can, if somebody comes to you and says, I'm not able to play tennis like I used to be able to play tennis, and I don't know, maybe I have a little bit of weight to lose. How can you help me? And then you find out that everyone in their family is overweight. Their spouse may be morbidly obese, could be. And when somebody comes home to the family and says, ta-da, we're going to eat healthy now, there is a lot of pushback. There's a lot of sabotaging going on. So it's not so simple. We don't live in a vacuum. There's other factors that can get in the way. I think we live in an all or nothing society. I had 110 pounds to lose. I was lucky my doctor said, you know, don't be surprised if you can't lose all of that weight. Once you get to this level, I'm going to be perfectly, or the labs are going to be good. Your A1C is good. You know, it's okay. And I said, watch me. And I did. However, sometimes success looks like this. Maybe the next time they see you in 3 months, they didn't gain any weight. That's success. I mean, sometimes I feel like, oh, I only lost 99 pounds. I didn't lose 100. Fail. Well, that's absurd. Again, we know this is the symptom. The weight is the symptom. But in my case, I wanted to not be diabetic anymore. And one way to do that was to lose the weight. So that's where I focused. And I want you to know that having to lose large amounts of weight is overwhelming and paralyzing. It is incredibly hard to envision a day where we will be able to lose that much weight. So for me, I broke it down into 10-pound increments. And in my mind, I never had more than 10 pounds to lose. And that helped me not get overwhelmed. Other people broke it down even further. Explain to your patients that you're in this together because feeling supported is critical. Discuss treatment options. What would they like to do? Please ask them. Don't just assume. Are you comfortable with whatever? They have a say in this. They may not know all the different options that are available to them, but we have to ask them. Agree on a realistic weight loss goal and the strategies to get there. So there's lots of ways to get healthy, to lose weight if that's the goal. But to tell a patient to eat less and move more is not a strategy. Nor is it helpful, nor I have a clogged tear duct. It looks like I'm crying, but I'm not. Though if it helps, I will. So basically when we're told to eat less and move more, we know we're on our own. You have written us off. You're frustrated. We're not doing what you've told us to do. We're not eating 1,000 calories today. You can't even eat 1,000 calories a day. I find this really interesting when it comes from physicians who are overweight. I thought, well, what are you doing? What's working for you? But we don't. We knew we were fat when we walked in. We really don't even need you to tell us that. We're pretty much aware of it. But it's overwhelming to make these changes, especially if nobody else is helping them or supporting them. So we need you to help by providing good education and resources. That means nutritionists, that means mental health professionals. You know, in my entire lifetime of everything I've dealt with, growing up with an alcoholic home, having all sorts of issues, nobody ever suggested I go talk to a therapist. Never. And I really wish I really want us to include mental health professionals in the treatment plan from the get-go. And we do need nutritionists, and we do need behavioral experts, and we do need folks who are compassionate. We don't need you to yell at us. We don't need you to be disappointed in us. We need you to support us. But just telling us to lose weight and walking out the door is useless. Please focus on the positive. If you have a patient who comes to see you and they've lost 5 pounds, please acknowledge it. I'm on Connect, which is the Weight Watcher board, and there are stories upon stories upon stories where for the first time in their lives, patients were excited to go see their doctor. because they'd lost weight. And by God, they were so happy. And then they got there and the physician said, you really need to do something about your weight. No acknowledgement, no good job. What'd you do that was working? What were your challenges? How can I help you? None of that. So what we know is patients are more engaged when they have a strong relationship with their physicians and providers. So couple of keys: don't assume just because you're their physician that they trust you. It has to be built and nurtured. Verbal and nonverbal communication should be consistent. Eye contact is paramount. You've got to look at us, really look at us, and you have to touch us. There is evidence out there that when health providers are dealing with obese patients, they don't want to touch them. And we know if you don't want to touch us. A lot of it in the nursing literature. Empathy. When you exhibit empathy, patients feel heard and seen and accepted. In fact, we almost feel human when you do that. We want to be respected. So attentive listening, nonverbal communication, and genuine communication is key. Stop typing on the computer, take a seat, and look at us. Research shows that sitting down increases satisfaction and makes patients feel like the communication is more satisfying. You may not even be doing anything different, but just the act of sitting down, making that effort to look at them, changes the perception. Patient-centered care and communication go a long way. Find out what's important to the patient. As I tell my residents all the time, this isn't about you. It's about your patient. I know my medical students who I oversee as well, they're used to all the attention, and the residents think it's all about them. But it really is about your patient. I promise you. You got to find out what they're most worried about. It's quite often different than what you think it is. Support matters. You can even say, look, I'm your partner in this. I'm not going to abandon you. And then follow that up with action. Understanding your patient's story. There's a host of reasons why a patient isn't responsive or compliant. And it's not because they're lazy, belligerent, or difficult. We got to find out what's going on. So how my primary care doc supported me: kindness, certainly, coaching, celebrated my wins. He answered all my questions, even all the silly ones. He offered valuable suggestions to me. Have you ever thought about, hey, I heard about this. What do you think? Would that help? What do you need from me? His number one question was always, what do you need from me? He didn't always direct the interaction. Often I did. Asking if there's something else they need to talk about significantly reduces unmet patient concerns and allows patients to guide the discussion. We built trust over time. We felt we could have very open conversations with each other. It allowed for more in-depth exploration and discussion. We didn't stay surfacey. We actually got into some serious stuff. He treated me always, still does, with compassion. It was clear he cared about me and my health goals. He was excited about my success as I was. He was the biggest cheerleader. He asked a lot about my home life and what challenges I was facing. He never, ever, ever let my weight define me as a person or as a patient. I did not lead with my weight. That was not the issue. And he never made me uncomfortable, even when we were having hard conversations. So, some final thoughts. Consider moving the scale to a more private location. We need to get on the scale, but not every time, unless I'm going under anesthesia. I don't know why I have to get weighed every time. And frankly, you don't. There's a lot of patients who are saying, no, thank you. I don't want to do it. It traumatizes me. It triggers me. It does. Somebody who doesn't have a weight problem doesn't understand that. But it is something we obsess about for weeks before we have a doctor's appointment is getting on that scale. And to pretend that that's not the case, well, you're missing a really important part of the patient experience. Framing the data on the scale. Talk with your patient about not letting the number on the scale define them, who they are as a person. It is one piece of data, just one. Got to increase medical school training and obesity around harm caused by social and cultural norms and messaging around body image. We have got to consider other factors, not just individual control factors. Making it all about the individual control factors is the easy way out. And it's not helping. And we have to increase empathy and compassion. No matter what the patient decides to do or not do, we still need to do or interact with empathy and compassion. Whether you agree with what they're doing or not, still need to interact with that empathy and compassion. Help them find all the resources they need. And quit talking just about weight. It is not about the weight. It's about what and why we are self-soothing in the first place. And I know as physicians, you don't have time to get into all that, by the way. You only have 8 minutes or whatever it is now. That means that's why we have to get other people involved. So it's not all on you. Identify, and I will challenge you to identify your own personal biases around weight. Do you interact with obese patients the same way as other patients? You might think you do, but you may not. Do you avoid touching them and looking at them? Are you judging them? In fact, a good way to figure this out is if you find yourself already frustrated and angry before they even come in the room. You see their name on the list and you're like, oh, I don't want to deal with that patient today. If so, your patients know this. They feel it. And you've got to find ways to own your own biases and address them. That is not our job. That's yours. All right, blatant self-promotion. So I have a podcast because everybody has a podcast, right? Mine is called The Work in Between, and it's available everywhere. We're just finishing up our first season. I'm happy to report that we're in 18 countries already. The focus of The Work in Between is that, you know, everybody likes a good transformational story. We love a good before and after picture, and that's what sells. But nobody likes to talk about the work in between that before picture and that after picture. And that's why I started this podcast. And we talk about the physical, the mental, the emotional, and the spiritual. We talk about all those pieces, and I bring in people way smarter than I am because I need to understand. I need to continue to grow. I need to continue to understand what things help me, what things get in my way, and to keep addressing those traumas and those issues that got me in this in the first place. Well, so, you know, a big part of this is that we're not alone. Everybody's surprised at how similar their stories are. So anybody who wants more information on that, I have cards. And I do talk to a lot of physicians. I talk to patients. I talk to anybody, medical students, nursing students, anybody who will listen to me, because we've got to change the narrative. We've got to change what we're doing because what we're doing is not working. But we can do better. This is a really great place to be where we're all going to come together. We're going to share stories with each other, and we're going to share different perspectives with each other. And hopefully we can move forward and do some great work. I am encouraged by it, and I hope you are too. So with that, I'm going to say thank you for your attention and your dedication to helping find solutions. We appreciate it. So thank you.